We picked to talk about cough, something very common, something everybody's had to some extent at some point in time. It is the top reason for people to see a physician in their office, which I did not know, I'll be honest with you, until actually my esteemed colleague and partner did the research for this. Fifth most common outpatient symptom, 30 million doctor visits a year. That's a lot too. So obviously a very common issue. Why do we cough? Well, it's a complex mechanism. It's a reflex, in which the body is getting rid of basically stuff that doesn't belong in our lungs or in our upper aerodigestive tract. An attempt to expectorate, if you will. Irritants, inhaled dirt, food, foreign bodies, microbes, mucus, bacteria, viruses, allergens. Allergens can be a lot of things. Trees, grass, mold, dust, things like that. We cough by forcing air out of our lungs under high pressure in an attempt to expel whatever it is that's irritating us or causing the issue. What can you do to treat acute cough? Acute cough is something that occurs for less than 3 weeks or maybe a few days. Fluids will help. Cough drops will help. A spoonful of honey in tea is something that we hear quite a bit. And that's why she included this, because we hear that from our patients, that they can help as well. Cough suppressants exist, but their efficacy or success in treating it is limited, really. There's dextromethorphan you can get over the counter. There's other sinus and cough remedies. We recommend them, certainly, but we don't necessarily see a lot of success with them. Expectorants are medications that, sorry, that's kind of small, but expectorants help to thin mucus so that you can move those, move the mucus and move the foreign body or whatever it might be out on your own. There are prescription medications too, and there's not much in that area either. Tylenol with codeine, something called Tessalon Pearls your doctor can prescribe you. We don't prescribe a lot. Codeine, we like a lot less nowadays because everybody's trying to get away from narcotics. It's not an opioid, but still a narcotic, so we don't like to prescribe that frequently, but it is quite effective. What causes a cough? We started to talk about that a little bit. Mechanical stimuli, chemical stimuli, vagus nerve stimulation. The vagus nerve is present in the ear, the pharynx, the larynx, which is the voice box, lungs, tracheobronchial tree, all the way down to your heart and in the gastrointestinal tract. The one part of that, the ear, if you come and you need the wax removed from your ear canal, part of the vagus nerve called the Arnold's nerve can make you cough when we do that. Feel really bad, the patient starts coughing, they can't hold still, and we're trying to examine their ear and they apologize. I don't have the heart to let them think it's their fault, and they always have to tell them that it's because of that nerve being stimulated. So we define cough or sort of categorize as acute, subacute, and chronic. Acute cough, less than 3 weeks. You can have upper respiratory causes of it, the common cold, a sinus infection. Most people have had several of those throughout their life, if they're adults. Lower respiratory tract issues like pneumonia, bronchitis, COPD, which is primarily seen in smokers, not all, or inhalation of irritants, smoke, either being just exposed to secondhand smoke or firefighters and things like that, fumes. Subacute cough, 3 to 8 weeks. That's definitely by that time you want to talk to your primary care provider and start to look into it, because it really shouldn't be lasting that long. Post-infectious cough is cough that begins with an uncomplicated acute respiratory tract infection. Patients may have a normal lung exam, normal chest x-ray. Sinusitis, that's what we see. We see sinus infections or nasal polyposis, causes postnasal drip. Patient comes in with this irritating cough they've had for quite some time. And asthma is another big issue related to cough. Chronic cough, longer than 8 weeks. If you've had a cough later than 8 weeks, please make sure you've had a chest x-ray. We have had or heard of cases in where I think they did it and they think somebody else, the primary care docs think we're going to do it, and where serious pulmonary issues have been missed because everybody thinks somebody else did it. So a chest x-ray is a good thing we want to make sure we've done. It can also be a key symptom for other medical issues, a chronic respiratory illness or extrapulmonary issue. Extrapulmonary issue meaning outside the lungs. Cardiac issue like Jerry and I were just talking about. Not exactly with what we were talking about, but you can have a cardiac issue and have cough as well. Almost every slide here could be its own discussion for quite a bit of time. The workup, the evaluation process usually involves at least some of this. Chest x-ray, as I mentioned, incentive spirometry is a test your doctor may do, bronchial provocation, sputum test, sinus imaging, that's what we do, bronchoscopy, a laryngoscopy is what we do. That's a scope of your upper airway. We can do that right in the office, put it right through the nose. Some of you have had it. Maybe you guys over there, maybe Aaron, I don't know. The 24-hour pH monitoring is done by the gastroenterologist. You don't want this. My sister had it. It's miserable. But it is effective in diagnosing gastroesophageal reflux disease. An EKG as well. Yes, again, the heart can be an issue. Postnasal drip. Now you're in our area. Allergies and sinusitis. Acid reflux, we talked about asthma a little bit, irritation of the ear canal. You can have otitis externa, or an infection in your ear, or a foreign body in your ear irritating the canal, making you cough. Vocal cord paralysis, believe it or not. Diagnosed one of these not too long ago in our office. Patient was coughing and coughing. You looked down there and one vocal cord wasn't moving. That's a whole other talk too. Tracheoesophageal fistula, which is a connection between your trachea and your esophagus, is something else that we see. Aspiration of a foreign body. I want to spend just a second talking about that. If you have kids or grandkids, they have this coughing episode and you can't seem to calm them down. Finally, after 20, maybe 10, 15 minutes, they're calmed down, they're fine. Look around and make sure you're not missing any little toys or any, because that can be aspiration of foreign body. And I've seen it. Mom went in, baby in the crib, coughing, and then she was fine. A couple weeks later, they brought her in because she had developed a fever. We got a chest x-ray, and one of the lungs was completely down because one bronchial tree was completely closed off by a foreign body. Luckily, like foreign bodies frequently do, it moved to just one side. She could still ventilate through one lung, and she survived. She went to the operating room, and it was removed. But it's something to think about. That I think we think the coughing's over, you're fine. It may not be. We already talked about smoking and other irritants. Medications, top of the list here, ACE inhibitors. If any of you are on ACE inhibitors, you can ask your doctor if you are. If you're on blood pressure pills. If you're on an ACE inhibitor and you've been coughing for a long time, ask about this. I've irritated several of the primary care docs saying, go back and talk to them about your blood pressure because ACE inhibitors can be causing cough. I know because I got it when I was on an ACE inhibitor. Post-infectious cough we talked about. Psychogenic cough we'll get back to in a second. Pneumonia. The middle here, pneumonia, COPD, chronic bronchitis, bronchiectasis, pulmonary embolism. You don't need to really think too long about those terms. Just realize that lung issues can be a problem. You have a history of a lung problem, that's where you want to look. Certainly, cancer is something we think about. Again, the chest x-ray comes in there. Chronic interstitial lung disease. Almost everybody has probably heard of whooping cough or TB. Don't see a lot of that these days, but once in a while we do. Non-asthmatic bronchitis, heart failure, Goodpasture syndrome. Well, her list is pretty complete. Wagner's granulomatosis, again, a lot of possible causes for cough. The most common causes, postnasal drip related to allergies, or reflux, acid reflux, or asthma. Those are the three most common. We treat number one and number two. We'll help you with asthma. If you're an asthmatic and you have chronic cough, you've seen your primary care doc, maybe you've seen a pulmonologist as well, we certainly help to manage those patients sometimes as well. These causes, are greater than 75% of all cases of chronic cough are these three. So that list, don't worry about that list. Just know from that long list that there are other possible causes, and you may need to investigate those. 99% of all cases involving non-smoking healthy adults, smokers cough. If you're a smoker and you're coughing, don't just assume that it's a smoker's cough. Every smoker gets it. You might want to talk to your doctor about it. Your primary care doc's probably getting a chest x-ray of some degree of regularity anyway, and at least on the lookout for that. Postnasal drip with upper airway cough syndrome, very common in our practice. Secretions from the nose and the sinuses stimulate the upper airway cough receptors. Inflammation increases the receptor sensitivity. Patients are doing this with some degree of regularity. The classic symptoms, doc, I got a tickle in my throat. They're clearing their throat. They can get hoarse. They're frequently also stuffy. Why? Because they frequently have allergic rhinitis or some sort of inflammation of the nasal airway. Cough may be the only symptom in about 20% of patients. The signs: inflamed nasal mucosa when we look in the nose, secretions in the posterior oropharynx. You can look in the mirror and sometimes you'll see the clear stuff running down the back of your throat. Underlying causes: allergies, chronic sinusitis, overuse of alpha agonist nasal sprays. That's Afrin or neosynephrine that you can get in the pharmacy. It's one of the most misused medications and you don't even need a prescription for it. You can use it, it's helpful for nasal congestion, but you only want to use it for 3 days and then you want to stop using it. No matter how you feel, good or bad. The diagnostic or therapeutic trial of a first-generation antihistamine or second-generation and a decongestant is often helpful to more clearly delineate what we're working with. The first-generation antihistamines are Benadryl. Almost everybody's had Benadryl before. Second generation are the non-sedating, like Zyrtec and Claritin. And you could go right to the non-sedating. If you've had Benadryl before, it makes you tired and you don't want to be tired all day, certainly can try that. Some people love Benadryl because it does make them tired. They use it to sleep. GERD, reflux. Who hasn't heard of reflux? You see all these advertisements on TV about proton pump inhibitors and acid-reducing medications. Very common. Basically, the acid reflux stimulates the afferent cough reflex. Basically, who cares about this slide? The bottom line is acid's coming up, it irritates your throat, and you're coughing because of it. A lot of people don't think about reflux when they think of cough. Matter of fact, when we were first in practice, a lot of doctors didn't. And we would get doctors disagreeing with us, and we get patients fighting us on it. Not so much here, but definitely in our first job, we got it all the time. You may not get heartburn. Matter of fact, with the laryngopharyngeal reflux, the reflux that comes up into the pharynx, you don't even get that. I think that's coming up. So cough can be a vicious cycle. Increase in intra-abdominal pressure makes us cough. That can also contribute to reflux, increase intra-abdominal pressure. Acid comes up, cough, increase in intra-abdominal pressure, reflux, cough, vicious cycle. When we're talking about GERD, gastroesophageal reflux disease, the classic symptom is heartburn, sour taste in the mouth. The definitive diagnostic test for that is that 24-hour esophageal pH monitoring that I mentioned before, which is a miserable experience. You might have to do it, but hopefully you don't have to. How do we make the diagnosis if we're not going to do that miserable pH probe? A trial of proton pump inhibitor therapy, acid-reducing medication, along with some lifestyle modifications, very effective. This slide, it says at least 2 months on the proton pump inhibitor. I've changed my practice to 3 months. Two of us were just at a continuing medical education conference, and we found out most doctors that treat this throughout the country are saying 3 months. I think the reason I was doing 2 months is because I'm just impatient. And I know I've had this before, and I know how miserable you can be on it, and I was having the patients come back too soon. So now I've moved to 3 months. And this is going to be hard to read from your seats, but if you come to our office, you'll get this on a piece of paper. Tobacco, alcohol, chocolate, peppermint, hot and spicy foods, caffeine, mint, chocolate. A lot of different foods can contribute to this. Now, if you do get our list from one of these guys, then realize that we're looking for you to look at what you're doing, what you're eating, when you're eating it, and where are you cheating. I have a truck driver patient of mine who drinks a 6-pack of Pepsi a day. And I told him, I know you guys got to stay awake on the road, I get it, but that's carbonation, that's caffeine. Is there another way that we can do this? I have another patient, a real nice lady, she eats 4 or 5 Dove chocolate squares every night, sitting on the couch watching TV. And they're not that big, and she's not really having a lot of it. She cut it from 4 or 5 to 1 or 2, and she's better. Another lady, chips and salsa at the assisted living. They come around you know where this is going, right? They come around about 7:30. She goes to bed at 8:30, and I didn't give her any medication. I said we're going to switch that first and see how we do. So you get the point with that. This says, if you can read it, no eating 4 hours prior to bedtime. I tell my patients 2. I'll take 4 if you can do it, but it becomes difficult at that time. If you're overweight, I don't think that's a problem in this room, but if you are, increased weight, intra-abdominal weight, increases the risk of reflux. Asthma we talked about. Just know that asthma can be related to cough. The big symptom there, in addition to cough, is wheezing. Go to your primary care doctor. Go to the ER if you're really struggling to move air, because asthma exacerbations can kill you. It's very serious. There are certain diagnostic tests for that, and I'll leave that to your primary care docs. It's spirometry and a methacholine challenge can be involved. They give you the inhalers, inhaled corticosteroids are effective in managing it. ACE inhibitor, again, it's in here twice because it's a big issue for us. 3 to 30% of the patients, and that is true. It took me about 2 weeks to get it, and I've got several patients that say, I've been on it for a couple months, doc. I'm like, well, still can be an issue. I had a primary care doc that said, oh, you've been on it. It was longer than this, actually. Finally got him to switch it only because it wasn't controlling the blood pressure anyway, and the cough went away. So they wouldn't even switch it until it wasn't effective for what patient was being treated for, and it worked. ARB is an angiotensin receptor blocker. That's what I had to go on because the ACE inhibitor was making me cough. Psychogenic or habitual cough is a diagnosis of exclusion. Don't worry about it. Diagnosis of exclusions are basically, we don't know what to call it, so we're going to make our own. Medicine's great. If you don't know what it is, you call it autoimmune, viral, or you just make up your own name. And if you make it, if it's long enough, people think you're intelligent. These patients are interesting, though. They don't cough when they sleep. They're not awakened by it. They're not going to be doing it during the SU game. Well, if they're down by 12, they might be. But, enjoyable distractions, it goes away. It is kind of an interesting thing. You talk about psychogenic. Is it in my head? I guess it may be. There are common triggers for that, taking in a deep breath, laughing. I had a patient, she said she was coming today, and she didn't. She would cough really bad when she laughed. She would actually sometimes pass out. Very interesting. Never really figured out exactly what was going on there. I can't remember exactly what we did either off the top of my head, but we've got it managed pretty well at this point. But, that's it. Yeah. That's kind of fast. Usually it's pretty informal. A lot earlier than this, but please ask any questions if you have them.
Can you go back one?
Sure.
Tell me about that again.
Psychogenic cough is basically a diagnosis of exclusion. That's probably the part that needs to spend more time on. So you've done the typical cough evaluation, which, let's start off with your primary care doctor. Probably includes a chest x-ray, physical exam, listening to the lungs. Then possibly a pulmonologist, which is a subspecialty area of medicine that involves only the lungs. And then, quite frankly, us. Usually, the primary care docs will send you guys to us, for us to put a scope through your nose and look at your upper aortic diastrophic. That's what he wants to do. And interesting, I was talking about how the laryngopharyngeal reflux, how they were fighting us on it, even the doctors back a few years ago. That's because the thought process was, we just want you to look in their voice box. That's all we want you to do. Don't do anything. Tell me there's nothing there. Well, and then we start treating the patients and they were getting better. But diagnosis of exclusion means you've done the typical evaluation and no one's been able to find a cause for it. And I do have some of those. There's what's the other one? Sounds like a genic cough. Remember that conference was the last one? Some neuromodulated, and they use I'll think of it the minute we're done. But
Gabapentin?
Well, gabapentin's what they use. I can't remember what they call it. Anyway, I think that's basically a bit of cough, habitual cough. We're not really sure. Basically, the thought is there's some unknown stimuli to this efferent cough. Efference is action, afference is sensing. So efference is the efferent cough process is stimulated by some unknown mechanism. But it is really interesting that it doesn't wake you up. If this was just firing, it does wake you up?
No, I don't wake up. When I laugh, I cough. When I'm on the phone, I cough.
Yeah.
I've had the scope with it. Nothing's wrong with my vocal cords.
I wonder if we were just at I was at the conference I mentioned a minute ago, and the last thing they mentioned was basically psychogenic cough that they were treating with something called gabapentin, which is used for neuropathic pain in diabetics.
I'm taking Tropamax right now.
Tropamax. I wouldn't.
I've taken gabapentin, but gabapentin
Didn't do anything?
knocks you right out.
Yeah, it does. I don't use it a lot, to be honest with you. And
That
you have to
water
ramp
is
it up.
the same thing. It just
You have
knocks you right out.
gabapentin. You got to ramp it up. You start at low dose. What was it, 100 milligrams a day? And I haven't done it in a while. Honestly, if you came in and we would do it, I would try it again, but I'd have to look it up to see exactly how they ramp it up again. Because it's used for neuropathic pain, and it's used. I was surprised to see this presenter present that as an option, but he's the president of the American Academy of Otolaryngology, so he's a big shot. So I suppose I should believe him. I would be willing to try it, but it's cause some pain, and it can have a lot of refluxes. Did anybody talk to you about reflux? That's the biggest thing that people don't. I have patients who argue with me on this, literally argue. I had a guy who I finally had to say, he's a diesel mechanic, and I said, if you put a diesel engine right here on the floor, put a gun to my head and said, fix it or I'll shoot, I'd say, shoot and save us all the time. You fix diesel engines, which I know nothing about, let me do my job. Of course, the knowing that I'm right involves treating him and the symptoms going away. Of course, I walked out there and clean, and doing this going, I hope I'm right. Because I would look like a knucklehead if I wasn't. Then he would have said, well, but it's one of those.
I'm going pulmonary tomorrow, and I take acid reflux.
Yeah, it's one of
I've done the allergy, alcohol allergy thing.
Yeah, it's a bear. It's a tough one.
I mean,
Yeah.
I don't know.
Yes, sir.
On the acid reflux, every now and then, if I eat before I go to bed, an hour into sleep, I'll wake up and I've got a bad problem. Okay, but that's not often enough to make me cough every day.
Yeah.
Okay, but for a while now, I've had a lot of times through the day where in my esophagus I will have an odd taste, like a sicky, sweet, maybe.
Yeah.
I don't know. Is that also acid reflux?
It's called water brash. Sour taste in the mouth, absolutely. I don't know, the gastroenterologists, the GI doctors, and the primary care docs, we don't see the heartburn patients, because heartburn patients, and I'm not saying you're exactly saying heartburn, but that fits more the gastroesophageal reflux, or GERD. They never make it to us. The patients that have heartburn get treated with PPIs, and that goes away. Sometimes the heartburn or the sour taste will go away, but they're coughing. Then they send them to us. And so the patients are one or two steps down our treatment algorithm by the time they come here. They're already on what we would put them on in the first visit. So when I meet you, when I see you, I put you on what I would have put in the second visit. That probably is gastroesophageal reflux or GERD. The difference between the two, and this is on her, which that she noticed and was profound, and I say to every patient after she told me about this, 20 episodes of acid regurgitation to cause heartburn, 5 episodes of acid regurgitation to cause laryngopharyngeal reflux, or the cough and throat clearing. And the reason is because once you think about it, you're like, duh, it makes sense. Our esophagus is much more tolerant. Think about what we do to it. Not necessarily you or you. Booze, hot stuff, sour, salty, acidic beverages, lots of different irritants go in the esophagus. And most of us outlive our esophagus outlives us. We die of something else. Esophageal cancer and esophageal problems are pretty rare. It's very tolerant. The larynx, on the other side of the equation, is very sensitive because, and I ask this question, I get the upstate medical students rotate through, and always ask this question, and they always get it wrong. What's the number one function of your vocal folds? Everybody says phonation, speech. And I said, no, protect your airway. I said, what's number two? They say speech. I say, protect your airway. They say, what's number three? I say, speech. I say, protect your airway. The reason for that is it's a very, very important concept to understand. And so let's say I'm scoping you in the office. If I could put my scope, it's not long enough to reach the esophagus, but if I could put it into the esophagus and drop a couple drops of water in the esophagus, you wouldn't even know I did it. If I drop a couple drops of water or anything off the end of that scope on your vocal folds, you go nuts, or you should. Because the first inclination is to slam shut and protect your airway. So that's why it only takes 5 episodes to cause problems there. You're reacting in a hurry. That can make this examination difficult, as you might think, of the patient that's awake. I'm more concerned, I'd rather have you be a difficult scope than some of these patients where you got all day. You're looking, the patient's talking to you about what they had for dinner there, all this. They're gonna have a conversation with the scope in their larynx. It's great for teaching. I get to teach the medical assistants. Everybody gets to look. But the immediate concern when you remove the scope is, can this patient protect their airway? So I think that is what's happening. I definitely would, you would want to move any meals or anything, no eating. I have some patients that'll come in and I say, you're not eating late at night, are you? No. I had a patient yesterday say, no, I'm not. I eat dinner at 6, I go to bed at 10. I go, okay. So, well, I have a bowl of cereal at 9, but I'm like, well, that's enough. That's enough. That's important. In anything, really. Some patients aren't tolerant of anything. Sorry.
Is lisinopril an ACE?
It is. Mm-hmm. I don't know how many times we hate ACE inhibitors, and the reason is because there's another problem with it called angioedema. It's rare, but when it happens, it's life-threatening. And I had a patient who had this wasn't here in Oswego before I came, longer, early in my career, who had been on an ACE inhibitor, had swelling of the lips or the tongue. That's a sign of angioedema. That happened. No one took her off. She had it again, and her tongue, imagine your mouth open as wide as you can open it, and it being completely filled with your tongue. That's what I saw when I got in the emergency room. And an anesthesiologist looking at me with an endotracheal tube in the mouth, going, trying to shove it in, it's not going anywhere. And we had 3, and by God's grace, we were able to get the airway and save her. I don't want to be there again, ever. The interesting thing about her is she had an event and should have been taken off of it and wasn't, and almost killed her. I mean, I never want to be there again. So we hate ACE inhibitors because of that reason, right? Now, does that mean there aren't a lot of people out there helped by ACE inhibitors? Well, yeah, there are. But when you see that, it sticks with you. And the cough thing as well. But I thought the cough thing was interesting because I got it myself. But that's one that you get some fighting on with the primary care docs. And and I get it because they may have had a bit of a challenge controlling your blood pressure, and that's important too. So if this is the only thing that works, then okay, then we have to try to work through it. Yes, ma'am.
Just wanted to say, my son has this kind of a cough and he had hypnosis.
Did it work?
No.
People, it's interesting. I know it's not exactly your question, but people will ask about, hypnosis and acupuncture and things like that. We, in our professions, treatment options should meet what we refer to as statistical significance. They've been studied in an X amount of patients, and variables have been controlled for as best they can be, and we see success. We can only quote you those numbers, so I'll usually say, hey, if I don't know of any study that's lended support to that option, but certainly if you're coughing and it's driving you nuts, and you've done everything else, I mean, I don't fault him for trying. Hey, at least he's trying to find a solution.
He had it 20 years before. I mean, and so it's like, and they've done I can't find anything. He still has it. So, I mean.
I don't mean to be arrogant, but did he see ENT? Did he see an ENT doctor?
I believe so.
He probably did. If it's been that long, probably did.
He had tests, he had everything.
Because I can tell you that I've been around people that they don't even know they're doing it. That's what you'll hear. Almost everybody's got a friend that's doing that. And you want to say something, but you don't. And reflux is the big thing people don't think about.
Well, I always said to him, I think it's nasal. maybe that pushed him to that.
You said he's your son?
Psychogenic.
I had a tough parent too. That can be traumatic for a kid. Yeah. Well, hey, you've got some support. We do have a diagnosis for him. I mean, it's, yes, sir.
I can't take Claritin or aspirin, but my primary doctor said it's okay for me to take even as a preventative Flonase.
Sure.
Absolutely.
And so, I take so many heart medications, I really don't want to take it.
No, understandably.
I don't have, maybe once every 2 weeks I'll take Flonase, just a quick squirt in each nostril. But when I'm sick, I'll use it.
Right.
It's the same way with Mucinex. I can only take the Mucinex that has the guaifenesin in. I can't take it that's got any of the other
Right.
chemicals in it.
All right. I was just going to say, you don't want any decongestants can raise your blood pressure.
Oh, yeah, exactly.
It can also cause prostate issues in men. So I don't use it a lot. If somebody's on it, they're not having any issues, the blood pressure's good, not having any prostate issues as a guy, then I don't take them off of it. But for you, based on our discussion prior to the talk, I wouldn't want you to be messing with it.
I take 5 heart medications.
Yeah, you don't want to.
And, mine is perfect now. For the last 4 years, mine never wavers higher than the 120s over the 65.
And you want to mess with that, not with everything that you've dealt with. Yes, ma'am.
I was wondering, do you need a primary care doctor referral to have allergy testing, and what method of allergy testing do you use?
Referrals are insurance determined, but our esteemed colleague Chris Mitchell's in the room. He can tell you whether you need a referral or not.
Yeah, it is payer specific.
Yeah, that's right. Just wanted to put you on the spot.
No, I appreciate it.
I actually know these guys right here. I'm sorry, forget about him. This is Tammy, this is Tony. No, I'm kidding. That's Tony, this is Tammy. They are the front line, and they are the ones you'll talk to. And if you get allergy testing, Lori, we call it party. And if you have a complaint, although I never get any, but sometimes. Lynn, who's our ops manager. But I'm glad they came because they are the ones you'll talk to. And these guys usually know off the top of their head, but not everything in that regard. Sometimes we have to give you the codes and the information, and you call your insurance, which is the best thing to do because the last thing you want is a surprise bill.
Do you do the scratch test?
Yeah, we do skin testing, so it's just a scratch test in the back, no needles. Test for grasses, trees, weeds, dust mites, molds, danders, feathers. If you can't undergo the testing for some reason, just based on medications that you take that would interfere with the test, then we will order blood testing. It's not quite as accurate, and it's actually a little bit more expensive. So we try to do the skin testing if we can. And we do it right in the office. Party goes.
Yeah. Funny story about blood testing. I got it done years ago, but nobody ever told me to stop taking Claritin before you went for the testing. So the first testing came out.
Yeah. If you come to our office, we'll look over all your medications and tell you exactly what and when.
Lori will tell you what to do.
Yeah.
Okay.
We give a sheet. We do have a discussion about that, and certainly double check with any questions. There's a couple in particular that we're really going to look for, but your medication list is completely reviewed on your visit, and then the medical assistants, our medical assistants really are quite knowledgeable, and they know what to look for too. But so between all of us, we'll review it more than once. So we'll let you know.
It's possible for allergy symptoms to come back, you had like shots years ago.
Unfortunately, yes.
Yeah.
Yeah, our immune system's constantly changing, which is a great thing if you get a vaccine or you have a certain flu strain 1 year, but it's a bad thing in that you can develop new allergies despite doing allergy shots in the past.
So, yes, ma'am. Oh,
I
we'll go back.
have asthma, and I'm on Benylin and Singulair, several other stuff. I also have gastric reflux, so I'm on like 4 or 5 different medicines for that. The problem is, every time I eat, I get coughing afterwards, and I cough up phlegm, thick phlegm, and stuff like that. And my doctor thought that perhaps I was aspirating food as I was eating or aspirating drinks. I cough constantly. I mean, there is no ifs, ands, or buts about it. I cough constantly.
Yeah.
And is there a test or something you can see if something's not closing properly?
Yeah, we can do a test called a modified barium swallow, where you would eat and drink different consistencies of food, liquids, and we put contrast in it and take pictures as it goes down and make sure that it goes from point A to point B correctly and not point C, which would be into the lungs causing a chronic cough. or an acute cough after eating. So yeah, absolutely, come see us.
Well, a friend of mine, Diane Meeker, is one of your patients.
Yes, ma'am.
Is there anything that you recommend to change the psychogenic cough habits?
Boy.
I mean, you're thinking,
Yeah, that's a tough one.
It's a tough one.
It's something that we normally don't treat, sometimes, sending you to possibly a neurologist, or even possibly some, behavioral changes through, cognitive behavioral therapy through a therapist too.
Yeah, our stress. and-
Biofeedback, those
Yeah.
sort of things.
Well, the hypnosis, the acupuncture, the things like that, who knows? I mean,
Yeah.
you want to, what you're looking for is some way to reset that. If that is the afferent cough reflex, how do you do that? And it's the reflex is believed to be well understood, but how do we reset that? Like a lot of neurologic conditions, it's a challenge because we're not really sure. And that's where the diagnosis of exclusions always go. Oh, it must be here. And sometimes it'll revert on its own. All of a sudden a patient will say, yeah, I got a bad case of bronchitis. I was in the hospital. I got antibiotics. I got steroids. I got all these things. And now I'm not doing it anymore. And it's like, great. Yes, sir.
With the upper respiratory infection, viral, can constantly dripping sinuses aggravate that?
Oh, yeah, absolutely.
Yeah, absolutely.
Yeah, we sometimes, there's certain specialties will refer to us simply because the assumption is that a constant drip, postnasal drip, is exacerbating or making an issue worse. What pops to my mind, even though there's, not any kids in the audience, but uncontrolled pediatric asthma, the pediatric pulmonologists will routinely, when they get frustrated, they send them to us to take out their adenoids. The assumption being that chronic adenoids, the adenoids are in the back of your nose, are just dripping down, and that's got to be the cause. Take them out. And frequently it is. We don't get that as much here because we don't have a PICU, pediatric intensive care unit, and we don't have the in-house ped service, but we've done it quite a bit in the past. Sort of the assumption being that that's similar to
Way
that.
to slow down the dripping sinuses.
Absolutely. Yeah, either by treating your allergies or treating the sinusitis with medications, or sometimes doing surgery too if the medical therapy doesn't solve the problem. We can open up your sinuses and just to allow better, drainage pathways, just to kind of
Some of
clean
that
out
be
that.
aggravated by deviated septum?
Absolutely, yeah. We make a quart of snot a day, and your more open side has more airflow going through it, so it will then dehydrate your nasal secretions, and you'll hang up in the back. You're supposed to just swallow all your snot and not feel a thing, but if it's too thin, it comes out the front. If it's too thick, it hangs up in the back. We see it all the time, and the solution to it is either fixing the septum, or you can just add more saline spray. You basically thin out those nasal secretions so they slide right down and you don't notice them.
It's yummy. Time for dinner.
Yes.
How about, so at our age, would adenoids come out that would help that?
Yeah, well, take that.
Yeah, if you had adenoid hypertrophy as an adult, which typically they start to shrink down when you hit puberty, every once in a while though, we'll find an adult that has adenoids that are enlarged, and if they are, we'll take them out.
And that does cause postnasal drip?
It can.
And contribute to it.
Yeah, it contributes to
Yeah.
it.
There's a whole process you go. The postnasal drip's the main complaint. I usually start with a nasal steroid spray like a fluticasone, and I will do allergy testing pretty much out of the gate. Partly because usually by the time they get to us, you guys have been dealing with this for a while. It's not new. I don't know what your initial approach is.
Yeah, very similar.
So you do. And I heard her mention surgery. That's usually a little later on. But I just had a guy yesterday and looked in his nose. He had a big polyp. His primary complaint was postnasal drip. By far. He said, I'm a little stuffy, and his left nasal area was almost completely plugged up by this big polyp. So
Get rid of that?
I hope so.
Okay.
That's my choice, but I tell them if I have any patients in the audience, they know that I've never made anybody's decision for them. We present the options.
Okay.
It's what's best for you.
But it could be real.
But quite frankly, I hope so, because I enjoy doing this work, and our administration has spent a couple $100,000 to get us the equipment we need to do it. So I like to use it, but it's his choice. But you know what? Sometimes though we will think. You're thinking inside what you really hope they do, and I hope he does, because I think it can. I think it'll do it. I think it'll wipe it out. And we get really. That's when you start to see us get excited. So if I can just do this, which is a lot of times, as you know personally, frequently or sometimes that's not the issue. That it's that easy. This will be that easy, I think. But Yes, ma'am.
What does the ACE inhibitor do that makes you have a problem?
Is that Dr. Sue from medical school? Is that her over there? Why does an ACE inhibitor make you cough? You know, to be honest with you, I can't remember what it is. It's a bradykinin issue, I believe.
Yeah, it's bradykinin.
Which is a cellular modulator in the breakdown of something before something after something. Yeah, honestly, I don't remember. It's related to something called bradykinin. And that's the angioedema process a little bit as well. It's crazy. I don't remember. That's medical school stuff.
It's bradykinin mediated.
Yeah, and we were not really sure. I don't think they know why why it does it, really. Because I think if they did, the lab rats, the scientists, would be able to get under the microscopes and figure it out, because it is effective in treating a lot of people's blood pressure. That's why it's still out there. That's why we tolerate these kind of side effects, because it's effective. The most important thing to think about with that is nothing's without risk. That's the key to understand. Is nothing's without risk. Yes, ma'am. Oh, sorry. I'm sorry.
What is an ARB?
That's an angiotensin receptor blocker. I'm sorry?
As opposed to what you just finished talking about.
That's an angiotensin receptor blocker. It treats the blood pressure in a different way.
Basically one step down in that pathway so that you don't release as much bradykinin, but there still is a little bit. So even with those ARBs, they can still cause a chronic cough. It's just not as often because there's less of that bradykinin being released.
All of this it's what's going on at the cellular level, especially and we took cardiology. Is that second year medical school?
Yeah.
And that's the last time I talked about any of this. And we both did very well in it, actually. It's one of the toughest classes in our medical school. For some reason, cardiology always has reputation of being very challenging, and it was, but we haven't looked at this since then, to be honest with you. But really, all those medications, what they do, certain cells in the body do certain things. It's like turning on certain light switches, and when one turns on a switch that has an adverse effect, we want to turn that off. Sometimes we only want to turn it off some of the time. So you want a medical therapy that will turn it off, but not all the time. Postnasal drip, same thing. I want to turn your faucet down, I want to turn your faucet off. I turn your faucet off, now you're too dry. So it's the balance, and that's the problem with some of these. But that's what most medications are acting on, a cellular component of either protein breakdown or how cells communicate. And there are people, many, who have more years of schooling than we do, PhDs and years of research on ACE inhibitors alone, entire careers. Bradykinin, that one molecule is probably many PhD cell biology theses. It's immense. So, Dr. Grady probably would definitely give you a better explanation on the pathophysiology of hypertension and how those medications work. At this point, I know when I read it, but explaining it's another challenge, just because it's not what we do every day. We just want you to be, and those terms are there so they will elicit questions for the people managing that for you. Hey, I saw something about ACE inhibitors, but I couldn't remember what it was. That's enough to get the question out, and Dr. Grady will say, "Oh, were you talking to the ENT guy?" All right. And he'll roll his eyes, and well, because we disagree in specialties, right? Everybody cares about themselves. I care about my problem. Well, I can't treat my problem without considering the other issues, so. Yes, ma'am. Oh, yeah, I'm sorry, I keep ditching you.
I know, you keep skipping her.
When a polyp is removed, is there usually a hole or a dip, whatever, and fills up?
Usually not, because usually the polyp is just sitting in the nasal airway, or it'll sit inside the sinus. As soon as you take the polyp out, that space around it wasn't really affected. It just kind of was holding the polyp.
It's technically.
Yeah, and it fills up.
Oh, let us put our hands on that. Take care of it.
What?
Yeah, it sounds like you might.
Or our instruments.
Really?
Yeah. So we can investigate your anatomy and go from there.
The guy I was mentioning that has the postnasal drip and has a big polyp on the left side. First, put a scope in the nose to look to see if we can see more extensive polyposis or not. But the CAT scan will tell you how extensive it is. And then you try to put the findings on that CAT scan with the symptoms you're having. I had a patient, the same thing. Pain in the right side of the face, that's it. No other symptoms at all. Got a CAT scan, polyp right in there, took the polyp out, the pain went away, done.
I had the polyp removed, but I didn't have no pain or anything. I had no symptoms, nothing.
Well, as much as we like doing this work, and Chris and Michael Harlovick and the administration wants us to use the equipment, I wouldn't consider doing that unless it was of sufficient size to be having an adverse
Something
effect on.
else going up to the eye.
That's different. Polyps technically, and she's right, at least in my experience, and we have different experience. We don't necessarily see the same things in the operating room. So, but the polyps can erode bone, and that can be dangerous. Just like the same gentleman that we were referring to. I said the negative, there's a positive, remember there's positives and negatives with treatment, there's positives and negatives with no treatment too. And one of the negatives by leaving polyps alone is that they can grow and make removal more complicated, subsequent removal more complicated, and they can erode bone. So if it's touching the bottom of your eye, it technically can erode the floor of the orbit and the eye can drop. Now, I'm not trying to scare you into surgery, but it's possible. It's not seen with a high degree of regularity. Polyps usually just kind of push on things, but if they get big enough, they can
Yeah,
do that.
and they usually take the path of least resistance, so if you have a
Yes.
polyp sitting right under your eye, it's gonna fill your maxillary sinus below, and typically would grow into your nose rather than pushing up through the bone, because there's a big bony barrier in between, whereas it can just kind of work its way into the nose and block things off. So really, the symptoms depend on, you know, how big that polyp has gotten and where it's at and what it's blocking.
But what I'm talking about too is like, get rid of what I experience every day.
To the bigger things, there's two things. Number one, yes, what you're coming in with usually patients are coming in with something hurts, something annoys them, something's impacting their ability to do the things they enjoy. And then the second thing, I had a guy today, because he chews tobacco, his dentist saw something on the roof of his mouth and wanted me to look at it, and it was nothing. But sometimes it's that, or skin lesions. We see a lot of skin lesions. We do a lot of skin cancer. Mm-hmm. Okay, that's not maybe bothering you. Oh, Dr. Morgan saw this little, and he wanted me to, But, so there's those two things. But that's why when you said they wanted to remove it and they wasn't having any trouble, they must not have liked the way it looked as regards causing another problem. Sometimes you want to be proactive because you don't like where this is going. And I've had a couple times where I didn't like the patient's choice because what I felt was going to happen was going to be, we were going to be in a real bad problem, and the step down the road was going to be very dangerous. And that we almost lost somebody here. We joke about it today because she wanted to go home and she had a life-threatening issue, and these guys probably remember I know Lynn remembers who this was. She did leave our office and came back, and thank God she did, and we were in the operating room that night. So there are those issues, but to your point, usually we want to address that issue. What are you not doing, and how can we help you do that?
Exactly.
Whatever it is.
Can that be fixed?
Well, it depends on what we're really talking about.
We'd have to do a nasal endoscopy on you, get a CAT scan of your sinuses, and really look at your anatomy to see what's going on to really come up with a determination of where we'd head next to. But potentially, yeah.
Polyps and cysts could be a cyst too.
Yeah.
Polyps and cysts are found in the sinuses sometimes as what's called incidental finding. You're CAT scanning a patient for headaches. You do a CAT scan, some of those cuts will go through the sinuses, and they'll see a little something in the sinus, send the patient to us. And the first thing I say is, well, your stuffy nose, runny nose, all the things that you guys know about now. We talk about those things, and the patient will say, no, I'm not having any of that. I just was having headaches, and my doctor did a CAT scan and saw this. So sometimes it's just a small polyp. It's not reaching up to the eye like you referred to.
Yeah.
We just say, well, we don't do anything.
And the word polyp is kind of a catch-all. It could be an anthraquinal polyp, it could be regular polyps, it could be precancerous polyps, it could be a mucus retention cyst. So it really depends on actually what it truly is. Or, sometimes we just call it a polyp, but it's something else.
Polyps are, the term's used kind of cavalierly, by us as well, really. And again, this guy, I wish he was here because he's the star of the show. With the polyp that I saw, I told him, by the way, it looks like a duck, quacks like a duck, smells like a duck, but I don't have DNA testing to prove it's a duck, I should say. So, because what we need to take it out, send it to Dr. Al, Dr. Al over in pathology for him to look under a microscope and confirm.
Right.
And we get a call once in a while saying, yeah, I thought so too, but here's what I found. And I say, let's call sale, you have to have a talk. So these, it does happen. Usually, though, it looks like that's what it is, or assist, but. Anybody? First man. Right? Yeah.
How do you feel about those neti pots or whatever it is that people use when they,
Love them. They're great.
do you?
Yep, absolutely.
Does it really help with allergens?
Yeah, because basically you're just rinsing out any of the junk that's up there, any of those allergens, so that you don't keep reacting to it.
Right.
It's great when you have a cold. They say the solution to pollution is dilution. So if you can, get all that stuff out of there, it's fantastic.
It's scientific study proven multiple times. For some reason, our profession likes to do studies on nasal irrigation rinses. I don't know why, but there's been several. And it's great for your kids and grandkids too. For little kids, if you can get them to do it. It does, if you've never done it, I've done it before. I don't like it. It feels weird. But that's if I'm sitting over there, up here. Have you done it?
I do it, and it doesn't feel weird.
Yeah, you get used to it, but.
Okay, so you're gonna go to her. No, you know what? You know the reason I say that? I say that because I'll tell the patients. Maybe I'll tell you. I will say that because I want the patients to know I don't like it either, but I do it. If I have a sinus infection, I do. I don't have allergies as bad as many of my patients. So
Get on the airplane, do it when you get off.
yeah, it's very effective. Yes, ma'am.
Yeah, the meal med rinses, and basically, the neti pot's a little bit more aggressive as far as rinsing stuff out, whereas the meal med rinses, a little bit less so, and then next you have just regular nasal saline spray, and then there's the mist next, and that's the most user-friendly. We typically recommend the mist for kids, or if you're a wimp like me, I like the mist better than doing the neti pot. I won't do it.
Don't spend your money on
It's
it.
great, but I can't hit my head either.
Yeah, don't spend your money on the expensive brands either. They are finer mist. It is. I like it better too,
mist
but I'm
is
too
nice.
cheap, so I just get that. I don't. Otherwise, it's just normal saline. It's just salt water.
And you can make your own.
You can make your own.
Brew at home.
Yeah, we have the recipe.
Boil hot water, let it cool to room temperature. A quart of water and a teaspoon of salt, and you can do a pinch of baking soda too if you want.
And if you got one of those-
Take a turkey baster or a baby bulb syringe and
The baby boulder.
just squirt away. Yeah.
But no, I want to go back to. I say it that way just so they know that no, it isn't all that pleasant, and to some people.
Yeah.
But it's very effective. Very effective. I just do the spray, but it's very effective. So.
Spray is just a saline one, is it?
Yep, yep. There's Arm & Hammer. The dollar store supposedly has it too. Ocean, yep. Yeah, Ocean spray. And some of them have it's just as you squeeze the bottle, and some of them have a little sprayer on it. The one with the sprayer on it is a finer mist, and it is a little bit easier to tolerate for some patients because it's finer. Some will say the other one's, it's running out my nose, and it kind of does.
It burns or,
So, yeah.
Some people don't like it.
Anything else?
Any other questions?
You guys, nothing? Come on, buddy, nothing out of you? Yes.
My son had a cough for like 6 months, and they finally did a biopsy of his lung and found out that he had an infection in his lung, liver, or anything like that.
Yeah, lung abscess. I went over it too fast, but where's the lung abscess? Who cares? But it's in there. And I started going through that list pretty fast because I realized some people were falling asleep in the back row. Ladies, right? I'm sorry, I didn't notice. No, I'm kidding. Because, it was really meant to just tell you guys, hey, there's a lot to be thinking about with this.
It's a big list,
It's a big list.
but 99% of it is the first three.
He had it for like 6 months, and I don't know who figured it out, but
Yeah.
Wonder if they did a chest X-ray out of the gate. It's having some knowledge and being able to ask the right questions is helpful, but patients don't know, and it's something that we should catch. And the reason I mentioned the chest X-ray is because I know another doctor who patient had seen a bunch of different, a couple different specialists too. And no chest X-ray had been done for a long time. They did it, and he had a tumor in the lungs, and it was pretty serious. Would they have caught it, and did he get treatment and get caught time? I'm not really sure how it all worked out. I think it ended up being okay, but it's because the assumption being that everybody was thinking, well, if you guys come to me for cough, I sort of assume you've had a chest X-ray, because it's early.
That's the number one thing on the list that you're going to do first, typically. So by the time you get to us, we assume that you've already had one. So I've tried to get into the practice of actually asking every patient.
I asked now.
I've had a chest X-ray, and then I've documented it in my chart.
Yeah, we asked now. After that story, and you learn from your colleagues, you guys learn from friends and neighbors and whatever. I urge you to use the access to information that we have, but to not self-diagnose. Most of the people in this room, most of us, did not grow up with any near this kind of access. You two down there, and maybe you, and maybe this guy. But the rest of us did not really grow up with this kind of access to information. And it's amazing when you think back to as a kid. You want to know something, you had to go to the library. Now it's right there. And some will come in our office and say, well, you hate Google. I said, I don't hate Google. I said, the problem is when you get information, you start to self-diagnose. That's where the danger comes in. Have your research help you come up with the questions to ask. I actually like it because we have a more intelligent conversation. Some patients will come in and even argue the diagnosis with us, and I say, every once in a while I had to say, well, you paid the copay to hear what I got to say. You can throw in the trash on the way out if you want, but this is what I think. So I don't know which one we need to start talking about that, but asking questions, ask questions. So it's good. Yes, ma'am.
Okay, I've had nasal really bad for years now, so that's something that really never goes away. You can get over-the-counter or prescriptions to help control it, but you can't really ever get rid of it.
I think we have some patients that say they hardly ever, if 1 is the worst and 10 is the best, if we get an 8 or a 9, we're happy. We want a significant improvement. The most important thing for me is that whatever impact it was having on your life, negative impact, of course, is removed, okay? I didn't want to go out to eat with anybody because I got a runny nose. Now you can go out to eat with your friends. Your nose may still run, but you're back to doing the things you enjoy. And I think we've been able to get that. I know we've been able to get that in a lot of patients. Are there some that you don't solve? Of course. This is a humbling way to make a living. I say that every day. It is, because there are some, I just had one today that he's better, but, of course he needs to quit smoking too, and he knows that. But, it's multifactorial quite frequently. But I think to address your question more specifically, I think, there's a lot of patients that can get significant improvement that they're happy with.
Medication eventually, you mean?
Without it?
Yeah.
Sometimes, you know what happens? Frequently we treat it. It's controlled with the medication. They call in these guys and say, hey, I need a refill, and I'm going to be in there in a month, but I'm out. Something happens that and these guys will take care of getting it sent in for them. They don't pick it up. I walk in the room and I say, so how you doing on the whatever? I'm not taking that anymore, Doc. I quit a month ago. I ran out and they never sent it in, or sometimes they forgot to call, or whatever the case may be, but they didn't take it, right, for the last month. I think they're in trouble. I think they're going to get yelled at. And I say, well, how do you feel? And they say, well, I feel pretty good. I go, well, maybe we don't need it. What do you want to do? They say, oh, I don't know, spring's coming up. I go, well, if the spring's your worst time, let's put you back on it. Or I say, call me if it comes back. We don't know why that happens, but sometimes it does. Sometimes the patients just, maybe it was a viral thing, or who knows? I mean, I wish we had clear, definitive answers for each issue a patient came in with, because it would make us look a lot smarter. Well, me, definitely. He already looks smart, but it would make me look a lot smarter. But we don't sometimes. And the good day, it's still a good day for me. If you say, I feel better, I'm back to doing the things I enjoy doing, even if I don't know why. I say, okay. I'll take credit for it, of course, because why not? But, I'm kidding, but, so sometimes I think the takeaway there is we can make it a lot better, I think, a lot of times. Anybody else? Well, thank you. Appreciate it.
Good morning, everyone. Do both of you treat the same patients, or she specializes more in one thing and you in another?
There's not much difference. Not much difference. I talk more than she does. If you want to get in and out, she runs on time more. Actually, well, I can't say that publicly, but there are people in the room who might be able to vouch for that. But as far as what we do, there's maybe a couple of procedures. If you get punched in the eye on the way out of here and you end up with an orbital blowout fracture, I do that, she doesn't.
If you have wrinkles and you want to be injected with Botox or Juvederm, I'm your gal.
Yeah. If you want breast augmentation, actually, neither one of us do that. Although I do know how. I mean, I'm not sure the hospital would let me, but
I don't think HIPAA rules for that.
thank you for coming. We appreciate it.
Yeah. Everyone have a good night.
Yep.